Chapter 2. Stroke Treatment. Regardless of why it happened, a stroke must be treated, and fast. When you get to the hospital, you'll encounter specialized doctors and nurses who will diagnose and treat the stroke. We invited two of the best to join the conversation. Dr. Jan Hinkle is a clinical nurse specialist and president of the American Association of Neuroscience Nurses. Dr. Tom Carmichael is an acclaimed neurologist, neuroscientist, and the co-director of the UCLA Broad Stem Cell Research Center. Along with Dr. Chu and Dr. Roth, they'll help explain what happens immediately after a stroke. Question 6. What should you do if you're having a stroke? Dr. Hinkle. You can learn to recognize a stroke by using the acronym FAST. The F in FAST stands for face. Sudden weakness on one side of your face. If you have sudden weakness in one of your arms, if you can't lift both arms, that's the A. If you have sudden problems with your speech, that's the S. The T is time. Time is brain. Time to call 911. You shouldn't call your family doctor. Call an ambulance and get yourself to the nearest stroke center. The ambulance drivers generally will know where the closest stroke-certified hospital is that can give you the best treatment. FAST. F stands for face drooping, A stands for arm weakness, S stands for speech difficulty, and T stands for time to call for help. Author's note. Many people who are suffering a stroke think they just need to lie down for a few minutes or that they'll feel better in the morning. Ignoring the symptoms of a stroke or delaying treatment can greatly reduce the ability of the doctors to provide brain-saving drugs and surgical procedures. This is what is meant by time is brain.
I had my stroke while on a family vacation. Looking back, there were a few early warning signs. Hours before my stroke, my uncle noticed me having trouble buttoning my shirt with my dominant right hand and using my left instead. I started feeling sick and took a nap in the hotel room with my mom. When I woke up, I couldn't talk. At first, my mom thought I was kidding. When I got to the emergency room, I went into seizures. Since I was only 10 when I had my stroke, my family and I weren't on the lookout for any warning signs. But you should be, David.
A tip. Most people who have a stroke are over 50, but the number of younger adults having strokes has spiked recently. While my brother's stroke was caused by a rare brain disease that could not have been reversed, most strokes in younger people are related to obesity, high blood pressure, diabetes, and smoking. No matter your age, be on the lookout for the warning signs of a stroke while addressing lifestyle choices that help prevent them. An ounce of prevention is worth a pound of cure. Question 7. Does it matter which hospital you go to? Dr. Hinkle. Yes. There's been a movement in the last 2 decades to establish what's called stroke systems of care. These are integrated regional stroke facilities. They make sure there are agreements between the hospital and the emergency medical services, or EMS, that are most commonly bringing people in via ambulance. They also make sure there's integration with the public and government agencies, so stroke survivors know where the resources are once they leave the hospital. The American Heart Association and the American Stroke Association now certify hospitals at 3 different levels in the stroke system of care: acute stroke-ready hospital, primary stroke center, and comprehensive stroke center. About a third of hospitals in the United States are certified as being primary stroke centers, meaning that the emergency room has written protocols and everyone knows what to do when a stroke patient comes in. They have transfer agreements with other hospitals, they have a director of stroke care, and most important, they have the ability to give the right brain-saving drugs. Author's note. Ask to be taken to a stroke-certified hospital if you have a choice. There are 3 levels of certification. An acute stroke-ready hospital has the ability to diagnose and treat strokes and can transfer you to a primary or comprehensive stroke center if needed. A primary stroke center has more tools and specialists available with designated beds and staff for stroke patients. There are over 1,000 primary stroke centers in the United States. A comprehensive stroke center has everything: dedicated intensive care for neurological patients, specialized neurosurgery, plus patient-centered stroke research. There are just over 100 comprehensive stroke centers in the United States today. Question 8. What will happen at the hospital? Dr. Carmichael. Most commonly, strokes are diagnosed with a clinical exam done by an emergency room physician or neurologist, followed by some form of brain imaging, an MRI or CT scan. There's a lot that can be done with early stroke therapies to limit the damage. So patients should expect a fairly substantial and very quick workup in the emergency department of a major hospital to understand the mechanism of the stroke and, if there's salvageable brain tissue, what might be done to open the clotted artery and allow blood to flow back into that brain tissue. Question 9. What are the immediate treatments for a stroke? Dr. Chu. For ischemic strokes, there are things that we can do to potentially reverse the effects, or at the very least minimize the effects. But these are things that have to be done almost immediately. One treatment is what we call mechanical clot retrieval, going up into the artery of the brain with a catheter, snatching that clot, pulling it out, and restoring blood flow to that part of the brain. Dr. Carmichael. There's one drug that's called TPA, tissue plasminogen activator, and it helps dissolve clots. You may have heard it called the clot-busting drug. It's been around since the late 1990s, and it's used for ischemic strokes. It has a very good effect the earlier you give it. The faster you can get a patient from the location of their stroke, say from the door of their home to the hospital, to receive the drug by IV, the better the outcome. Stroke doctors call this door-to-needle time. There's a very strong focus in most stroke units on quick transport of patients to the hospital and then administration of this drug. After about 4.5 hours, the risk of giving TPA outweighs the benefits. Question 10. When would a stroke survivor need surgery? Dr. Carmichael. There are a couple of conditions related to a stroke itself when surgery is appropriate. In a certain percentage of patients with ischemic strokes, there will be a swelling or edema. That's called malignant stroke, when the stroke causes fluid from the rest of the brain to rush in. If the brain swells, the skull can't expand, so the brain will collapse in on itself. The surgeon goes in and removes a bit of the skull to allow the swollen brain to expand out and not damage or push on adjacent healthy brain tissue. Another indication for surgery is when the stroke is caused by a brain hemorrhage, which happens in 15% or so of strokes. Removing the hemorrhage by draining the blood or repairing the ruptured blood vessel can help reduce the symptoms on the adjacent brain tissue. Question 11. What is a mini-stroke, or TIA? Transient ischemic attack. Dr. Chu. The term TIA versus the term stroke is meant to denote that the symptoms, which are the same for the two, are transient or temporary with a TIA, so they resolve completely. The term TIA versus the term stroke is meant to denote that the symptoms, which are the same for the two, are transient or temporary with a TIA, so they resolve completely. Typically, the effects will be observable for a few minutes to several hours, but the effects disappear within 24 hours. It is very important that you do not ignore the symptoms of a TIA. The risk of a stroke after a TIA can be just as high, if not higher, as the risk of having a second stroke after a full-fledged stroke. This means that you need to seek medical attention immediately after a TIA, just as you would if you had actually suffered a full-fledged stroke. It also means that you now have an opportunity to take preventative measures so that you can avoid a full-fledged stroke, where the consequences can be permanent or long-term. Question 12. Are there any drugs available that can help the brain repair after a stroke? Dr. Carmichael. Unfortunately, there is no real medical therapy that promotes brain repair at present. There are likely to be some in the next 5 to 10 years, but at the moment, there is no drug or pill that someone can take to enhance recovery in the brain. However, there are a couple of roles for the selective serotonin reuptake inhibitors, or SSRIs. These medicines, commonly known as Prozac, Paxil, or Zoloft, were originally developed for depression. One of their main and well-substantiated roles is in treating post-stroke depression. Up to 30% of patients get clinically depressed after a stroke, and some of this may be from the stroke itself. Just like a stroke interrupts circuits that control movement, it can interfere with circuits that control emotion. So depression can be a real neurological side effect of a stroke. And people who are depressed after a stroke do not recover as well. So one clear benefit of using these drugs is to treat post-stroke depression. There was also one clinical study that suggested that Prozac, given in the first 90 days after a stroke, may enhance recovery of movement. This could have been because it enhanced the ability to engage in rehab and more fully participate by controlling depression. But there's also a signature in that data that it may indeed have enhanced recovery. So early after a stroke, in the first couple of weeks to months, there may also be a role for these SSRIs in enhancing recovery. There have been small case reports or studies that suggest that boosting L-DOPA, using a Parkinson's disease drug like Sinemet, or stimulants like Ritalin may help. But whenever attempts have been made to repeat those results or use larger case studies, they've never borne out. The problem is that many physicians feel the need to do something, so patients end up on a lot of these drugs. One of the things we often do in neurorehab is take patients off the drugs to see how they do. If the drugs are helping, patients should deteriorate, in which case, of course, we put them back on the drugs. More often than not, they just sort of accumulate these drugs over time by seeing different physicians who want to help. The physicians prescribe the drugs, but all drugs do have side effects. So if there's no medical evidence to support them, it's usually not worth taking them because of the risk of side effects.
A stroke survivor asks, what other medical concerns do I now have to watch out for because I had a stroke?
Dr. Chu, the obvious concerns, such as paralysis on one side of the body causing problems with motor function, or an impairment in speech or language, you know right away. Once the dust settles and someone who's been hospitalized for a stroke goes home, often it will become more evident if there are cognitive deficits. However, another thing to watch out for is dementia. Many people think of Alzheimer's disease anytime the term dementia is used, but in fact, strokes are the second leading cause of dementia after Alzheimer's. Cognitive problems that get worse over time instead of staying the same or improving may be related to vascular dementia. Changes in mood, such as depression, can occur in as many as a third of patients after a stroke. This may become apparent only later, so it's important to watch for it. Seizures can happen in about 10% of patients who've had a stroke. Sometimes seizures can be in the immediate aftermath of a stroke, and sometimes they can occur weeks, months, or even years after a stroke. Seizures happen because the scar tissue caused by a stroke results in the abnormal electric firing of the brain cells. Dr. Roth, people with strokes are actually at risk for a number of medical conditions, especially early after a stroke. For example, blood clots. what we call DVT or deep vein thrombosis or clots in the legs, and pulmonary embolisms or clots in the lungs can be very serious complications and are very common. Up to 60% of people get those early on after a stroke, but the risk period goes away after about a month or two following that stroke. Likewise, having infections like pneumonia or a urinary tract infection can be fairly common. A lot of the complications come from immobilization or not moving much, like pressure ulcers or contractures, or a stiffening or tightness of the limbs, as well as the blood clots. Those things are big problems of being sedentary and immobilized. Dr. Hinkle, to help prevent blood clots in the legs, getting up and moving as much as possible as soon as possible is the key. If you're at high risk for DVT, the doctor will evaluate you for blood-thinning medications, such as low-dose heparin, so that the clots don't form as readily. If you see one leg looking larger than the other and it's red and swollen, call the doctor and don't massage the leg. Bruising is going to happen more readily if you're on an anticoagulant medication. The biggest complication is the chance of a gastrointestinal or GI bleed. So if you see blood in your stool or unusual bleeding from anywhere, you want to call the doctor right away. Talk to the team about what to expect from any new medications you're on. Takeaway points. Learn to identify a stroke by using the acronym FAST. F stands for face. Is the face drooping on one side? A stands for arms. Can the person raise both arms? S stands for speech. Is the speech clear and coherent? And T stands for time. Now is the time to call 911. Get to a stroke-certified hospital if possible to get the best treatments. The neurologist will decide if the stroke patient needs the clot-busting drug, clot removal, surgery, or other treatments. After the immediate medical treatments, there are no drugs to speed recovery, although treating depression may be a good idea. A mini-stroke, or TIA, requires the same medical attention as a full stroke. After a stroke, be on the lookout for signs of these other complications that can result from inactivity, medications, or damage to the brain. Blood clots, bruising, GI bleeds, pneumonia, urinary tract infections, pressure ulcers, contractures, depression, seizures, dementia.